acid at the source. Smoothies, only from Tums.
Well, I know that a lot of you, and we too, have so many questions about Ebola right now. So we've been looking at what you're asking on Twitter and Facebook, specifically under the hashtag Ebola Q&A, and we want to put some of those questions to experts for you.
Yes, and we have two here with us. Dr. Esper of the University of Pittsburgh Medical Center. Also joining us, infectious disease specialist Dr. Frank Esper of University Hospital's Case Medical Center in Cleveland. Thank you, gentlemen, for being with us. I want to get to Lisa Conyers, her question through Twitter. First, why is Ebola not considered airborne when a sneeze with saliva drops can be put into the air? Let's go to Dr. Adalja first.
So we draw a distinction between something that's transmitted through a sneeze and something that can be suspended in the air. So diseases like the common cold and a sneeze from an Ebola patient is something that's transmitted through big droplets that only go about 3 feet. They don't get suspended in the air like in tuberculosis or in measles. So that's what we mean by airborne. And for those, you need special precautions like negative pressure rooms where air only flows in and special masks. But Ebola doesn't transmit that way. It's just through sneezes. It can only travel about 3 feet and then it falls to the ground.
Okay. Dr. Esper, for you, John O'Neill tweets under the name Red Hand New York, and he wants to know if Ebola is not spread through the air, as he was just saying, then why are doctors dressed like astronauts when they encounter patients? Good question.
Yeah, it is a great question because it's very impressive at how much we gown up for. There's a lot of abundance of precaution that we take when we have come in contact with Ebola patients or with any other infectious patient. A lot of times we have full body gowns that protect from getting secretions on our clothes. We wear masks. Again, we have that 3 feet rule, as we just mentioned, to ensure that secretions don't get into our mouths as well. And then sometimes there's a face shield or an entire hood, also to ensure that we don't get any splattering on our face, near our eyes, and things like that. So it can be very impressive. And sometimes as a physician, we are not too happy about how much we have to wear because we don't want to scare people. We don't want to feel imposing to the patient. We want to comfort them, but sometimes it's very hard to do when we're geared up like that.
You know, what scared a lot of people is what they heard from the UN chief, that it would be a, quote, nightmare scenario if Ebola were to mutate into some airborne strain. Dr. Adalja, how likely is that mutation?
That mutation is very unlikely. All viruses mutate, but we've never seen a virus that's spread through blood and body fluids become airborne. And think of HIV, for example. That's spread through blood and body fluids. It's been through millions and millions of infections, but yet has no airborne characteristics. It's not just a switch that a virus turn. There's a lot of evolutionary trade-offs that a virus has to do to acquire new properties, and there's no evidence that this strain would go airborne or that it even has the capacity to do so. Okay,
you know, Dr. Esper, even if the experimental Ebola drug ZMapp were a cure-all, and we know that it is not, we should say, the company that makes it apparently has run out of supplies. Why does it take so long to produce this?
Yeah, well, what they're doing right now, specifically with the ZMapp, that's a lot of specific antibodies against this virus, and at least in certain small trials, both with monkeys as well as a few patients within humans, it is shown to suggest that there is some benefit. But in order to make those antibodies, they have to go through very rigorous changes in cloning in order to produce the amount of antibodies, and they still don't even know exactly how many, what the correct dose is for these antibodies, and so they're probably getting a lot more than they need to because they just don't know just yet. Further trials as they go forward are going to be to ensure that it works, to ensure that it's safe, and to try to figure out exactly what the right dose is. But maybe right now we're just using too much, and it's very difficult for us to produce these kinds of antibodies.
We know that Wright-Boll and Brantley, Richard Brantley and Nancy Wright-Boll, they received ZMapp, and then Kent Brantley, and then Richard Sockwell received a transfusion from Brantley, the first three Americans. Now that we have Thomas Duncan in Dallas, how is he likely being treated right now, Dr. Adalja?
It's unclear how he's being treated now. There's a few options with some of these experimental drugs, but the mainstay of his treatment is going to be good supportive care. That means IV fluids, fever control, anti-nausea medications, maybe supplemental oxygen, and he'll be probably briefed on all the different options that are available. They're all very scarce, but I'm sure he will be offered some of these experimental therapies if he's able to consent to have them, because they are still experimental, and it will be interesting to see which of the few that we have he actually receives.
Dr. Esper, Eric Neiman wrote to us saying, given the healthcare structure in the U.S., what is a realistic worst-case scenario for an Ebola outbreak here?
You know, you have to understand that the control of Ebola is directly related to how much resources that you're able to apply to that outbreak. And so it's one of the reasons why there's a bit of a dichotomy where we try to say how confident we are here that we could do it, but then we talk about what's going on in West Africa and we're very concerned. We are able to dedicate a lot of people, to dedicate a lot of money, to dedicate a lot of resources to controlling this outbreak, whereas they can't do that so much in most of those parts of West Africa. What is a realistic expectation? I don't expect to see a substantial outbreak of individuals from this person in Dallas, although some of his close contacts, the people who are living in the apartment with him, may come down with those symptoms, and that's one of the reasons why they're being monitored so closely. But if we were to see another person with Ebola, it's only going to be one of those very close contacts, or it's going to be someone new that enters our country from an infected region, or it's going to be one of the healthcare workers that are working very closely, but they are using very meticulous infection control strategies that I have a feeling that the healthcare workers are going to be okay.
Okay, good to know. Dr. Adalja and Dr. Esper, thank you both very much for being with us.
Thank you, gentlemen.
Thanks.
It's good to be here.
Thanks for having us.
So police encounter a lot of roadblocks during a high-speed chase. Traffic, maybe even a suspect jumping from a car,